Hey everyone, so in this video here we're going to be exploring 4 different ways that you can approach improving joint range of motion by appreciating the context surrounding that reduction in joint range of motion. So joint range of motion represents the space that we have available between interacting bony segments. And this space that we have between those segments affords us the ability to move those segments relative to each other to allow us to interact with the world around us to engage in certain tasks. But why is it something that's important for us to assess and address within a rehab context? So if, for example, you have a client that has difficulty with a certain task and they have pain in a certain body region, let's focus on the knee in this video. If they have pain in the knee during a certain task, then assessing the range of motion capacity that is available at that knee is something that's very important for us to consider during the assessment process. Now, to simplify the reasoning process across each of these 4 scenarios, we're going to keep certain features consistent across each scenario. So that's going to be the joint of interest, which is going to be the knee, the range of motion that's limited, knee flexion, and the aggravating task. This is the task that the client is having difficulty with or experiencing that knee pain during. Now, of course, in a real world situation, a client that comes to see you with knee pain will likely not have one specific aggravating task that they are having difficulty with. But to simplify the reasoning process, we'll keep these things consistent. Now, we're going to show you this aggravating task on the screen here, but this essentially reflects a client that is avoiding knee flexion to reduce increased knee pain, but as they load into the lower limb to bend forward to pick something off the ground, to put on their shoes, for example, they still have to experience load through that lower limb, but they're keeping a very stiff knee. So they're avoiding knee flexion, but they're still experiencing some pain with that stiff knee. The way they're getting around that avoidance of knee flexion is by increasing the contribution from the hips. So they're increasing hip flexion to reduce the need to bring that knee through further flexion. So the stiffness around the knee is still irritating the knee, but they're avoiding further knee flexion to reduce further knee pain. So the first thing that we have to consider here is how are we going about assessing that knee flexion range of motion? Are we using a local assessment where we're concentrating the focus on the interaction between the femur, the patella, and the tibia in a supine position, for example, where you're passively bringing that heel to the glute to assess the available knee flexion range of motion and reducing the contribution from other joints? Or are we using a functional task to assess things? Many practitioners will not use more isolated assessments because of the thought that they're non-functional, and they'll use more functional assessments like a client performing a certain task. And so it may be the aggravating task that we looked at before on the screen, where a therapist might ask the client to do something like that. They note that the client can't bend their knee, and then they say that, okay, you're limited in knee flexion. And what can happen then is that you don't get a clear insight into what that knee is actually capable of, because you're assessing the range of motion within the context of how it's coordinating with other joint ranges of motion. So you're assessing that knee within the context of the ankle, you're assessing the knee within the context of the hip and the rest of the proximal structures. So there's more of a coordinative demand during a functional task, which limits your ability to get a clear insight into what's actually available at the knee. So while yes, looking locally at what's available at the knee may not give you a very clear insight into how that knee interacts during a certain task, but it's very important when you're gathering information to make a decision about what you're going to do from a rehab standpoint. Because what's also important to understand is that just because a client isn't demonstrating that knee flexion range of motion in a multi-joint task does not mean that they don't have access to the available knee flexion range of motion. It may just be a case that they're not engaging with that knee flexion range of motion in that multi-joint, more coordinated task. And we need to further explore and gather more information to determine why. Okay, so moving into scenario number 1 here. again, we have the same location, knee pain, same direction of range of motion limitation, knee flexion, and the same aggravating task. But remember, the nature of the aggravating task here isn't really important. This just reflects a difference in looking locally and looking more globally or coordinatedly at a multi-joint task. Because very often in the rehab space, we tend to forget what's happening locally and just try to modify or adjust the way the client is doing the task. That can be very appropriate in certain situations, like we'll explore in this video, but in other situations, sometimes we have to go locally as well. So don't worry about the aggravating tasks that we showed here. Naturally, they'll have many aggravating tasks. Any task that involves knee flexion would really be likely an aggravating task for the client. But we're just using that as a feature, just to simplify the clinical reasoning. So we have to consider the potential contributors to this pain experience, okay? And that's what's going to be different across these 4 different cases. So we're going to add in those unique subjective and objective features in combination with these 3 consistent features to help us kind of critically think about how our approach may change when these unique features are combined with these consistent features above. So we have a client that came to our clinic or our gym with a pain experience at the knee that emerged 3 weeks ago after a big spike in how much tennis this client was playing. So a lot of quick change of direction, more than usual. They woke up the next morning and they had a very stiff and painful knee, and it's been stiff and painful ever since. But the key feature with regards to this client here is that they did not give that knee a chance to calm down. So we can hypothesize that that knee was acutely overloaded during that experience. They had a lot of muscle guarding, protective muscle guarding around the knee joints the next morning, but they did not avoid the activities that were re-irritating them, that were aggravating them. So they continued to persist with the activities that were irritating the knee, not giving it a chance to calm down. Okay, so that's very, very important to consider there, because that's going to influence then what we do from a standpoint of trying to restore that lost range of motion. Because it may not be a case where we have to look directly at the knee to do any fancy corrective exercises or anything directly at the knee to improve that range of motion. We may just have to give that client the opportunity to modify their current aggravating activities to give that knee the chance to calm down. Okay, so objectively, they had 100 degrees of knee flexion passively. So they got to 100 degrees, and that was the point where the pain became intolerable. Okay, so we could have pushed further, but again, the pain was the stopping point there. So from a rehab standpoint, considering, again, I know this is not enough information to make a clear decision, but conceptually we can say that we likely need to just modify this client's aggravating activities to give that knee the chance to calm down. And by doing that, that may help us give the knee the chance to calm down, to reduce that aggravation, to reduce that muscle guarding as a result of that acute overload. Okay, so like I said, it may not be a case where we have to do anything directly to the knee to gradually increase that range of motion, but by reducing or by modifying and adjusting, manipulating activities that are aggravating the knee, re-aggravating and re-irritating the knee, that will give the knee a chance to restore its lost range of motion. Okay, and of course then we have to gradually return this client to their goal task as well. So that's something that's important to consider there. So again, scenario number 1, not necessarily anything that we need to do directly at the knee, but we need to modify the client's current activities that are consistently re-aggravating the knee. Okay, so moving into scenario number 2. So same location of pain, the knee, same direction of range of motion limitation, knee flexion, same aggravating task, and the same other unique features across the contributors, the objective measures as well, but we're introducing a change in the injury and surgical history in this client. So we just want to introduce this to consider how this will influence the way you approach trying to expand that knee flexion range of motion. So let's say the client told you that they have always experienced some intermittent knee pain prior to that acute overload after playing tennis. But they also say that they had a meniscal surgery 2 years prior to that acute overload, okay? That wasn't really rehabbed well. And even after this acute overload, they've been resting their knee. So they've been avoiding any kind of aggravating activities that would have continued to irritate and aggravate the knee. So they've tried to modify those aggravating activities to give the knee a chance to calm down, but that hasn't really been having any kind of positive change. With that history of knee pain, which is not necessarily an injury, but a history of pain, will certainly influence how that knee is experiencing load. It may change the way that you're engaging that knee during day-to-day tasks. But of course, a history of a surgery that wasn't really rehabbed well will very likely influence the range of motion capacity at the knee and the tolerance to load at the knee as well. So we have to consider here that perhaps there was already a potential loss of knee flexion, range of motion there prior to this acute overload, and that there was likely a reduction in the tolerance to load in that available range of motion prior to this acute overload as well. So that's likely, well, it would certainly influence the way you should go about approaching the expansion of that range of motion. We're just talking about range of motion, of course, in this video here. So instead of just modifying their aggravating activities, we need to use more direct local strategies to expand that knee flexion range of motion. So we're considering how the tibia is interacting with the femur. We're considering using manual loading strategies to be more targeted with our load application. And then we're using more targeted other load active application strategies as well, where we're delivering a gradual exposure of load and stress to gradually expand that range of motion, but also build tolerance in that range of motion around the muscular tissues, the quadriceps, the distal quadriceps, the distal hamstrings, the proximal gastroc, for example. So we have to consider that within the context of how we would influence that range of motion, knowing this change in potential contributing factors and how that was going to influence the rehab approach. Okay, so very different to scenario one. In scenario one, simply modifying the aggravating tasks to give the knee a chance to calm down seemed appropriate. But now with this new information, the options in scenario one would not really be as appropriate. So we need to not think of just modifying the task, but look locally. So again, considering that difference with what's happening locally and what's happening coordinatively or globally, where that knee is also interacting with the ankle, with the hip, with the rest of the body. Whereas when we look at things locally, we're trying to narrow our focus on what's going on locally. We're not thinking about the hip, we're not thinking about the ankle, we're not thinking about the task, we're thinking about what we can do locally to expand that range of motion. Okay, so moving into scenario number 3 here. So again, we have the same features above, but very different unique features across this case scenario here compared to scenario 1 and scenario 2. Okay, so we have a client, and again, the next 2 scenarios will be very different from case number 1 and case number 2, because in these next 2 cases, the client will have full passive range of motion locally through knee flexion, but they're going to be struggling to express that knee flexion range of motion during a more coordinated multi-joint loaded task. So again, we're still trying to improve range of motion. We may just not be trying to do it locally. We're trying to afford the expression of that range of motion in more of a coordinated task, which may require a different approach. Okay, so looking at potential contributors, we have a gradual onset of pain, so no clear mechanism of injury. Objectively, like we said, the client has full passive knee flexion range of motion, but they did have some discomfort through the range, a 3 out of 10. But the key thing here was that the client had poor tolerance to load locally through the quadriceps and the hamstrings, so more of a muscular reduction in tolerance here, not necessarily a reduction in range of motion. Another key thing to consider here was that the client struggled, like I said, to demonstrate knee flexion during a multi-joint task, during the aggravating task, in a lunging task, for example. So again, it was a case where they had the local range of motion, but they couldn't demonstrate it in the more global, coordinated, multi-joint task. So from a single joint perspective, they could, but the local muscular tissues couldn't tolerate load there. So it was, from a rehab standpoint here, we had to gradually increase the muscular load tolerance. So this is the way you're affording more local range of motion during a multi-joint task. You're increasing the muscular tolerance to load through that available knee flexion range of motion. And you're making sure to do that first, because if, for example, similar to case number 1 and case number 2, If you were to not look locally, but try to do this during a multi-joint task to try and gradually expand that knee flexion during that task, we have to remember that a multi-joint task allows for or affords more of a sharing of workload and muscular load across multiple joints, so the hip, the knee and the ankle. So by engaging in a multi-joint task like that to try and address local knee load tolerance, muscular tolerance, may not be appropriate, because you're giving the individual the opportunity to distribute load away from the knee. So you're not actually increasing the local tolerance around the knee by engaging in a multi-joint task. So this is again another scenario where we may not want to look at the more global task first. We may want to look locally at the knee still, not to improve range of motion locally, but to increase muscular tolerance locally through the available range of motion. And then we can integrate that during a more integrative, more coordinated task where we're sharing load between the hip, the knee and the ankle. So going locally first here before we go global into a coordinated task. And again, why might this increase range of motion? Increasing the local tolerance to load through the muscular tissues. And again, we have to be more mindful as to how we expose the quadriceps and hamstrings to load here, because let's imagine in this case scenario here that when we exposed the quads and hamstrings to load locally during the assessment, the client had an increased pain experience. So how we go about dosing the application of load will require more mindfulness behind the application of load. We have to be more mindful as to how we go about doing that. So increasing things locally, increasing the load tolerance locally around the muscular tissues at the knee may help to increase the client's confidence with engaging into that knee into flexion during a loaded lunging task. It may reduce the sensitivity of the knee to that loaded knee flexion. So essentially you are, like I said many times before already, forgive me if I'm repeating myself, but we are targeting the local muscular tolerance, not targeting local range of motion. We're increasing muscular tolerance through the available local range of motion to afford the individual the ability to engage in that knee flexion range of motion during a coordinated task. If we were to do that in a coordinated task because there's a sharing of workload across multiple muscular tissues and joints, it may not actually increase the local load tolerance at the knee. It's certainly an option, but we have to, again, step back and consider things from a local and coordinated perspective. Okay, so finally moving into case scenario number 4 here. Very, very similar to case number 3 in that the pain came on gradually, but some other key differences here as well. One being that the client had an MRI recently and was told by their doctor that they had some cartilage damage and that they should avoid doing too much weight-bearing activities like lunges, for example, which would be the aggravating task where you're bringing the knee through loaded knee flexion. So you can imagine that this would create a lot of fear surrounding weight-bearing activities where we would have to bring that knee through loaded knee flexion. And so this is really going to change how the client is engaging with that knee flexion range of motion during that multi-joint task. So the key thing here as well, similar to case number 3, that this client had full passive knee flexion range of motion, but no real discomfort, but just more apprehension as we were bringing that knee through flexion. Unlike case number 3, this client had good local load tolerance to the quadriceps and hamstrings around the local knee region, but was just unable to express that knee flexion range of motion during weight-bearing tasks where you're integrating the ankle, the knee and the hip all together. Okay, again, integrating the MRI findings and the conversation that they had with their doctor, this was likely secondary to a fear of doing further damage and a lack of confidence with that. So the lack of range of motion was secondary to an increased fear and lack of confidence with bringing that knee through that knee flexion range of motion. So one of the key things here from a rehabilitation standpoint will be to educate the client about and help explain to them about how these MRI findings can be very common and very normal in active individuals, but also educate them about the importance of weight-bearing activities for the health of the knee long term. Okay, just to simply over time and gradually reduce that fear with weight-bearing activities and increase that confidence with bringing that knee through a flexion range of motion. Now, considering the fact that the client had good local load tolerance around the quadriceps, hamstrings, around the knee in general, doing local muscular loading strategies wouldn't necessarily be appropriate here, or would likely be helpful. Same thing with the range of motion. Directly changing that range of motion here wouldn't be appropriate because they already have that access to that range of motion. So the key difference here was that the client had a limitation in range of motion in that unique task, but it was secondary to fear. So we couldn't just have the client go through progressive loading in that multi-joint task, similar to case number 3, before we built or after we built that local load tolerance. But here it was secondary to a fear. So we had to educate the client and be mindful of the narratives that we're using to describe how they're getting to that range of motion, why it's important, and be more mindful of the progressions there as well. So not just using strength and conditioning principles to make it harder, progressively more challenging and harder over time, but really being mindful of how we're educating the clients and exposing them to that multi-joint task and gradually expanding that range of motion as a result. So in this case here, education would be key. So if you made it this far, thanks so much for listening. And the reason we wanted to share these different case scenarios is because there's always lots of discussion across the rehab space about different techniques to improve range of motion. But it's not as common to discuss how differences in the client's story and the client's unique experiences may influence how you go about influencing that range of motion. And it's also important to consider that while an individual may have the available range of motion locally, it doesn't necessarily mean that they're going to engage or demonstrate that range of motion in more multi-joint tasks or coordinated tasks, okay? So hopefully these different case scenarios here will help you consider things differently and approach things differently within your own approach.